welcome to Slide Review. Today we are taking a last look at some Dermatopath with melanocytic lesions. As always, we start with our disclaimer. So if you have any questions about the disclaimer, they can either go in the comments on the video or on our Twitter pages. We have both of those links posted below. And we're roughly going to break everything up into melanocytic tumors, as in benign tumors, and then those premalignant lesions and malignant lesions. We have a lot of cases to go over, so this is going to be quick. So case 1, what we have here is a relatively irregular macule. And we say irregular because you can see some variation in the color along the edges. But there's hair coming out of it, which in Dermatopath is generally a good sign. And we can't really get a sense of overall size or anything like that because it is zoomed in. So looking at our slide, we can see that there's something happening in the dermis, and it looks like it's leaving the epithelium alone. So if we go in, we can see that yes, our epidermis is relatively benign. We do have a lot of pigmentation along our basal epidermal layer, and that's all right. But this is the lesion that we're seeing. So we have a lot of cells that are somewhat round. Some of them are ovoid or spindled. Down here we can see a better spindled one. And they have somewhat prominent nucleoli, but we are zoomed in rather high. Other things that we'd want to take a look at with these kind of lesions are if they involve things like hair follicles or adnexal structures, and what we see is the same cell population is actually going underneath these structures. So when you see these spindled cells that may or may not have pigment in them, they may or may not be vacuolated, these are melanocytes, and when they go underneath adnexal structures, we call that features of like congenital features. So what this actually is a congenital nevus. Okay, anything else that we can kind of talk about on this? The rest of the dermis is relatively bland. Again, these are more melanocytes coming down. But you really shouldn't see atypia in them. You may or may not see mitotic activity, but it just generally should look relatively the same. Like even if there's some that look more epithelioid or some that look more round, they should generally be within the same family. Like you shouldn't have cells that look really atypical and cells that don't. So this is just a congenital nevus. Happens in 1% of neonates, so 1% of our infants, and by definition it's present at birth. So this is what people would call a birthmark. And most common site is the back if it's very large, and when they say large they mean larger than 20 centimeters, okay? So there's a huge variation in size, and generally they're going to be brown to black. They tend to be symmetric, okay? They can have a pebbled or hairy surface, so we can see in the picture here how we have hair coming out of it. Again, that's usually a feature that we see with benign lesions. And with those large lesions, you may or may not see satellite nevi, and what that means is just like smaller nevi in the area. The surface of the birthmark itself can be thickened, and it can have increased or darkened hair. And so this can make it very difficult to follow for change over time, because remember, we want to make sure that we're clinically following these lesions for our ABCDEs, right? And then here in this picture you can just see there's a lot of pigmentation in some areas, but it's a completely dermal lesion. On microscopy, again, you can have a relatively wide range of appearance, and it tends to be rather heterogeneous, which just means it's not totally the same. Like our example, there were areas that were more spindled and areas that were more ovoid. The epidermis can either be normal or hyperplastic or acanthotic. In our case, it was relatively normal. You can have lentiginous melanocytes. You can have focal pagetoid scatter. Remember, pagetoid scatter means that you have this relatively superficial scattering throughout all layers of the epidermis. Okay, it's not just restricted to the basal layer. Small lesions may only be junctional. So dermal lesions are down here, junctional lesions being at the dermal epidermal junction, okay? They may or may not involve the lower reticular dermis or even the subcutaneous tissue. And remember, our superficial dermis is called the papillary dermis. That's where you have that loose connective tissue, and then your reticular dermis is relatively prominent, thick collagenous stroma. When you do have dermal involvement, you may or may not have that periadnexal or perivascular predominant. And again, like, that is a feature, a congenital feature, and it's more common in your small nevi, and the dermal involvement can be very diffuse, as we saw in the slide example that we had. And what you often have is these single melanocytes that are in between the collagen bundles. We kind of had like this nodular pattern, but as you went into the deeper dermis, there was some spreading out of the melanocytes. And when they say with maturation, what that means is as we progress downwards into the lesion, they do become a little smaller, and again, like, for the most part, when we see cells and we say that they're maturing, that means that the cells themselves are, for the most part, getting smaller, not larger. And again, other things you can see is if it involves the muscle. Again, the adnexal structures comes in there. It can involve nerves, and they can also cluster around vessels too. So that's something you want to keep in mind. And here we go. We're talking about our nodular proliferations. They may or may not have heterologous elements, and heterologous elements means something that is a normal tissue, but it does not belong in the location that it is at. So that could be something like, is it bone or cartilage? Just things that aren't in the right location. Okay. Again, your melanocytes can have variable morphology, like we talked about, and they can be relatively poorly demarcated from the overall nevus. With nodular proliferations, you won't see that epidermal involvement. You should not see necrosis, and again, you should not see atypia. If you have some mild atypia, again, it should not be prominent, and you may or may not see mitotic activity. Your differential, again, your acquired melanocytic nevi, so those are nevi that we get as we age. You want to think about atypical nevi, dysplastic nevi, as well as melanoma. So again, these things would have relatively prominent atypia or just really bizarre atypia, and the history is what helps you, along with that deep dermal involvement of the adnexal structures for congenital versus acquired. And for cosmetic reasons, they may cut them out. They may biopsy them if they aren't sure what they are, but these are fine to just observe. There is a 5% risk of cutaneous melanoma as well as neurocutaneous melanosis with these lesions, so they're not entirely benign, but 5% risk is still relatively low. So this is your congenital nevus. Moving on to case 2. So what we notice right away is these are the same tissue, but clearly we have something here that we don't have here, and that's all this brown pigment. So we're going to take a look in here, and what we notice is essentially we have this sea of very, very intense pigmentation. There is this relatively fibrotic or sclerotic background, and we can, I don't know how much we'll be able to comment on the cells themselves, but some of them look maybe a little elongated, some of them are These ones that are larger and round are probably maybe macrophages that have picked up pigment, because these long, slender cells and maybe these round ones, these are the actual cells of interest. So you want to keep that in mind, because those are your melanocytes. I guess we should use the proper term. So macrophages that pick up all this extra pigment. So these are melanophages, which makes sense because macrophages come in and they eat things that aren't supposed to be there. So melanophages just means that they've ingested all the pigment. Let's see if there's anything else. I mean, honestly, most of these are melanophages. There aren't a lot of the spindle cells in between, which is good for this lesion. But you can really appreciate that sclerotic background here. Not much else to say. Your epidermis is relatively bland. A little bit of parakeratosis here. But not much to say about that. So when we have these heavily pigmented lesions that have relatively sparse melanocytes, but lots of melanophages, and the sclerotic background. So this is a blue nevus, okay? And these are very common, okay? And they can occur at any age, but obviously we're going to see them more in children than adults. And again, here's something that occurs in females more than males. And basically they can occur anywhere but either arms, legs, and face. Those are your most common areas. But it pretty much lists everything. They can even occur internally, okay? So that's something to keep in mind. And these are very, very well demarcated. You can imagine that they're almost like a coin marking, or like someone took a brown marker and drew this lesion on. They tend to be slightly raised, but there are variants that are hypopigmented, so instead of being very dark, they would be light, and they tend to be relatively small. Okay, so as we noted, these tend to be rather hypocellular lesions with short fascicles, and the Gren zones. And again, that dermal sclerosis that we noticed, where we had these very thick collagen bundles in some areas. The actual stromal collagen itself will vary from case to case. So our case didn't have a lot of stromal collagen, but what was there was really sclerotic in appearance. So the two cell types that we noticed in our case, and these are the cell types that you need to notice, are those very elongated spindled melanocytes. We didn't really appreciate the dendritic processes, and this is because it was so heavily pigmented, but we did see lots of those melanophages. So again, they have that very coarse cytoplasmic pigment, so they're very round, plump, and they're going to be very dark, filled with melanin granules. There's lots of variants, as with everything. And you can see combinations of all these things. Ours was just the run-of-the-mill blue nevus. Your differentials, so you'd want to think about a lot of things that go into what subtype of blue nevus you have. So obviously, like, we'd be thinking about things like Spitz nevus or congenital nevus, or is this again atypical, or is it in fact like a melanoma? So the differential that's listed there, those are specific to different subtypes, but really the pigmented lesions, you'd want to think about things that morphologically look similar, okay? Treatment for these is excision, and they have absolutely no malignant potential. Well, no significant malignant potential, right? There's always a risk of something having a malignant transformation. But they can even leave these alone. It's just generally these kind of lesions are somewhat bothersome to people, so they tend to want them taken out. Moving on to case 3.
It's like a Mongolian spot.
It's like a Mongolian spot. That's probably because it's a Mongolian spot. Okay. So here's your slide.
Wow. That's a very nice arrangement.
Yeah, it's super spread out.
Yes.
But yeah, 3 levels of the same
thing. Yeah. Okay. Well, let's start from just a random place. I think they all look very similar at low power.
Yeah, they do.
I think this is the same piece actually.
No, it's actually like.
Oh yeah, it's not. Okay. Never mind.
It's slightly different.
They
yeah.
look similar, but anyways. Okay, so we have. What do we have? So there's some ink there. The skin, the epidermis looks decently normal. Maybe some solar elastosis.
Okay.
Maybe it looks kind of like edematous a little. And then.
What you're looking for is very subtle.
Yeah.
And it's within the dermis.
A few melanocytes here in the basement of the epidermis. There's maybe a melanocyte here.
Maybe. I promise this is not a trick. They are there.
Am I looking at the right piece?
So you want to go deeper dermis.
Deeper dermis? Okay.
See them now?
Like these things?
Mm-hmm.
They're like banana shaped?
Not quite, but I see why you're saying that. I do.
Thin? Some sort of melanocytic stuff.
Yes.
Okay, yeah, it's right here. Alright.
Okay. So you said Mongolian spot, but we're in pathology. So what would we call this?
Dermomelanocytosis.
Yeah. Okay, so lots of different names for this. Thank you. Nevus of Oda, Nevus of Ido. So again, these all refer to different locations, as well as Mongolian spot. So these are often present at birth, but they can occur later, okay? So even though in med school we're often taught that these are birth lesions, they can develop later on in life. And they're most common in patients with Asian ethnicity, but they can occur across all ethnicities. So your nevus of Oda involves your conjunctiva of the eye, can also involve the trigeminal nerve. There's the nevus of Ido, which that should be pushed out since it's not under nevus of Oda. Nevus of Ido is specific when it involves the shoulder or the deltoid. And the Mongolian spot obviously being the most well-known, where it involves the lumbosacral region. There is a variant, of course there's a variant, right, that can involve the extremities, and it should not involve the back, which has some overlap with the blue nevi that we just saw. So what you're looking for are these very long melanocytes in the dermis, and what we were seeing where they almost we describe them as they're somewhat banana shaped. Those are the dendritic processes that are coming off the melanocytes and extending into the dermis, and these tend to be present around vessels, nerves, as well as the adnexal structure. So if you're having a hard time looking for it, and clinically they're saying this is a Mongolian spot or a nevus of Ido, nevus of Oda, that's a good area for you to look. Okay, they tend to be relatively sparse, as we saw, and you should have a relatively normal dermis. Otherwise, there shouldn't be sclerosis like we were seeing in the blue nevus, and you shouldn't really see the melanophages, which again we also saw in the blue nevus. So rarely you can see melanophages, but even if you did see them, it should not be to the extent that you would see in blue nevus, okay? So that is important to note. And your differential, for the most part, you're looking at relatively different nevi. Of course, with Mongolian spot, because it's occurring in children, there's always the concern about abuse or blue nevus. And really, these are relatively benign lesions, so we don't actually even have to treat them. They can do laser treatment on them to lighten them up for cosmetic reasons. But it's really very rare for these to have malignant transformation. With the nevus of Oda, there is a rare risk of deafness, and there's also inheritable storage disease that's associated with very extensive Mongolian spots. But again, these are extremely rare conditions, so for the most part, clinicians are going to look at them and they're probably going to say, oh, this is a Mongolian spot, or this is a nevus of Oda, and they may just leave it alone. Case 4.
Random spots, nevuses. Nevi,
yes, that is.
Around, yep.
Okay, it almost looks like an archipelago.
It looks like someone took a bite and left a bunch of nevi.
Yeah. But yeah, they're all small, they're round, papules.
Relatively uniform if you take each one as
Yes.
take each one individually.
Yeah. And the coloration is very uniform throughout the lesion as well. Each of them are kind of separate, so you want to consider that. And looking at our slide.
Okay, with some skin. And then epidermis looks a little thickened. Dermis. There seems to be sort of some disruption of the reedy ridges. This is normal here, and it goes abnormal here, so something's going on. So let's go in for a deeper look and see what's going on here. Well, this is not what this epidermis should look like. There's all these cells. Let's see if I could make a head or tail. Well, there does seem to be some melanocytes in there, in the epidermis. And then
those melanocytes or something else.
Oh, could there be something else?
They could be something else.
Oh.
So, actually, pretty much all the cells you're looking at are melanocytes.
Oh, are they all melanocytes?
So,
wow.
well, they're not all melanocytes, but your melanocytes, they have that little bit of a halo.
Okay.
They have the smaller rounded nuclei. In some areas, they're a little more spindled.
Okay. Yeah, okay, so they're all melanocytes. I think they're extended down. Are these melanocytes down here? Or they could be, I think they're just lymphocytes maybe.
Yeah, I think those are just superficial lymphocytes.
So it seems like it's epidermal. It's pretty much confined to the epidermis. I'm not seeing anything in the junctional area.
Yeah.
So
what do you think this is?
simple nevus.
Simple nevus, okay. Well, this is the realm of DermPath. So we like to very specifically characterize our nevi. So when we have nevi that only involve the epidermis.
Epidermal. Superficial
Okay.
nevus.
Okay.
I don't know.
So what we would call this would be a junctional nevus.
Oh, junctional doesn't include the junctional region here, or
Yeah, but it doesn't extend into the
dermis.
dermis. Yeah.
Okay.
I know, it seems somewhat like a misnomer. But yes, this is an acquired nevus or simple nevus, and this is a junctional type. So we're going to go over the acquired nevi. Hint, hint, there will be a couple more cases. Okay, so a lot of different names. Junctional, compound, intradermal, or common melanocytic nevus, common mole, nevocellular nevus. And these just tend to increase with age, and they often develop during adolescence. So these are not present at birth. So remember, with our congenital nevi, those were like our birthmarks, so they're present at birth or early development. And these are more common in fair-skinned individuals or Caucasians, and they're often secondary to sun exposure. Okay? They can occur anywhere that there's skin, and the difference between them is your junctional tend to be relatively flat or slightly raised, and they're usually pretty small. They're less than a centimeter, okay? Whereas your compound lesions tend to be slightly raised. They may be brown or flesh colored, and they may or may not have hair. Remember, we were talking earlier about how hair is usually a sign that something's benign. And your intradermal lesions tend to be papules. So you see as we go deeper, the lesions are becoming a little more prominent. They may or may not be pedunculated, and they tend to, again, be brown or flesh colored or pink, and they also may or may not have hair involving them. Okay, so on microscopy, again, we kind of recapitulate a lot of the things that we were talking about grossly. For your junctional component, you often have nests of melanocytes at the ends of your lesions, and your nests are often centered both at the tips and sometimes the sides of the reedy pegs. And your melanocytes tend to be relatively rounded, and they may be single and present within the basal layer of the skin, okay, so amongst the basal keratinocytes. You can have pagetoid spread, and if that's present, we want to look for parakeratosis. Remember, parakeratosis is a great way for us to find lesions, or a great clue that we need to look for something else. If there's an intradermal component, what happens is there's different layers of your melanocytes. So when it's talking about melanocytes near the base, it's talking about the base of the lesion, so the deepest aspect of the lesion. And what we notice is, again, the maturation, where our superficial cells are going to be larger, more epithelioid, and as you go down towards the deepest portion of the lesion, they're going to become smaller and more lymphocytic-like. You may or may not see type C cells, and these will be present at the base if they are there, and these are those spindled and very neural-looking cells. You should not really see mitotic activity in these lesions, and you will see melanin pigment either in the junctional or superficial dermal nests, okay? Again, you're not looking for pigment that's as intense as your Spitz nevus, okay, or your blue nevus, but you should see some pigment. And we did see some pigment in the lesion that we picked for our junctional component. Okay, lots of different patterns, but for the most part, you're going to be able to pick these out relatively easily. The difficulty comes in whether or not you're looking at, is there any atypia? Again, if you see those congenital features, you want to be thinking about congenital nevi instead of acquired. Can add in things like your neurofibroma, because your type C cells, if they're present, they have that neurotype appearance. Again, we have to think about melanoma because it is a pigmented lesion. And for treatment, these are required, and for the most part, they don't do anything, or they can do excision. Again, this is usually cosmetic, and there's a very low risk of malignant transformation with these lesions, so they are considered benign. So, okay, our first case. This is a junctional nevus, okay? So the larger picture is showing our case, and then we have some other pictures to just kind of give you an idea of what you're looking for. Case 5.
So it's just a little nodule.
Mm-hmm.
So looks like it's not really colored in any way. It's pretty light. It's not really melanocytic, but that could be all right. Pretty symmetrical looking.
Okay.
Yeah.
Does it look raised or flat?
It's raised. I mean, it's a nodule.
Okay.
Yeah. Oh yeah. So.
Yeah. So you can pick any section.
Yeah. So striking is there's something in the dermis here.
Yes.
Yes, and then so yeah, these are melanocytes.
These are melanocytes.
Yeah. And they're found mostly in the dermis, and they seem to be getting, it's kind of hard, the orientation is kind of weird, but do they get to seem like they're getting, let's see. They look like they're kind of getting smaller as you go deeper.
Okay. So I guess the next question is, do you have an epidermal component?
Not at low power. Yeah. Well, maybe there's some like in the, yeah, no, not in the epidermis, but dermal component. Not seeing much in the epidermis.
Right, because we'd be looking for an actual nest. Like,
Yeah.
normally you have melanocytes within your epidermis, but what we're looking for is nests within the epidermis. And I'm going to save you a little bit of time because they aren't there.
Okay.
So when we have nothing but dermal involvement, what do we call these lesions?
A compound mucus.
So it's just involving the dermis.
Oh, dermal mucus.
Yeah, so dermal or intradermal. So again, acquired nevus, dermal, and again, the big picture being our case, and then just some more examples. And then case 6.
It's another nevus of some sort.
Yes.
That has a little, I mean, still wild circumference, but maybe a little less, so it's pretty uniform in color, so it's not really concerning for melanoma grossly.
Okay. Yeah, and it's hard to make out on the screen, but it does look like maybe it's a little thickened and maybe a little raised. Okay, so here is your slide.
Okay, so again, we have some melanotic lesions here, and it looks, well, it's definitely in the dermis, and it looks like it's maturing, sort of going deeper down, kind of just gets smaller and then disappears pretty much. Ends up here in the area between the reedy ridges. I think there's a component in the epidermis.
I think so too.
Yeah. So this is a compound.
This is a compound
Yeah.
nevus, yes. So this is actually a nice area because you can see the nests of melanocytes, and here's a really good one with the pigment that's in the epidermis, and then you can see the dermal component down there as well. So this is a compound nevus. Okay, so moving on to case 7.
So this is, oh, okay, it's like a very widespread, ill-defined area of melanocytic lesion. Looks slightly raised, but it's like unevenly so.
Mm-hmm.
Our skin, epidermis looks pretty good at low power. Ooh, what are these things?
Yeah.
There's these pools of very like yellowish, sort of amorphous brown ochre color.
This is ochre color, yes.
color.
There's that buzzword.
Okay. Yeah, this one looks weirdly horn, crescent, banana.
Banana, there's
shape.
your other
Okay.
buzzword, yes.
But most of these are not banana looking. There's a few, but
There's a few, but it's the
Yeah.
the pigment, the color.
Yeah.
You do have some bananas, so what? So you clearly know
Ochronosis.
this. Yes, this is ochronosis. So this is a rare condition, okay? So it occurs in 1 in a million. So literally, if you have this, you are 1 in a million. And if it's genetic, then esophagitis is more common. Okay. This is also known as alkaptonuria or black urine disease, or association with alkaptonuria and black urine disease. And this tends to occur in younger adults, so we're looking at people who are around 30 years old, and there's a very slight male predominance. For genetic, that makes more sense now. So genetic, we see it more in Slovakian and Dominican ethnicity, but exogenous, so up top where it says esogenous, that should be exogenous, which, I don't even know that esogenous is even a word, so exogenous. And that tends to occur in darker skinned individuals. It can occur in any site, but it tends to be this very dark blue-gray macular discoloration. Remember, macules are just very large patches, okay? And it can occur pretty much anywhere. Again, any skin. There can be heart murmurs if there's valvular pathology. They can have decreased range of motion in extremities and their spine if it's involving that. And there can also be pain associated with that. And because of all the pigmentation, any fluids in these areas can also be dark. So whether we're looking at cerumen or sweat or even breast milk can all be dark if they're in areas that are associated with ochronosis. So what's common to both alkaptonuria and exogenous ochronosis is that ochre-colored banana-shaped fibers in the superficial dermis or papillary dermis. These are very infiltrative to both the collagen and elastic fibers, and they just give this very disorganized appearance to the collagen. You will see pigment incontinence with melanin in the dermis. So what that means is that you're going to have macrophages within the dermis that are going to have melanin pigment ingested. And then your epidermis is going to be NSPF, which means no significant pathologic findings. So basically, there's nothing to see in the epidermis in these cases. For patients who have exogenous ochronosis, you can have these this colloid milia or even granulomas, but they will be pigmented. So again, that's very unique to this, and that tends to occur in higher stages of the disease. They can also have, again, the transepidermal or transfollicular ochronomic pigment. So again, that's where like the colored sweat, the colored breast milk. So all these things can be seen with exogenous ochronosis. The molecular, so again, when we're looking at alkaptonuria, so that's your HDD gene mutation on chromosome 3q, and what this leads to is increased HGA, and then you get HGA deposition. Your differential goes from things that are very benign like melasma, which again is pregnancy induced. There's also substances that can cause pigmentation. There's dermatoses that we didn't go over a couple weeks ago that can also cause pigmentation. And our nevus of Oda also makes an appearance because, again, these are lesions that generally involve the face, but they can occur anywhere. For treatment, if it's genetic, there's really nothing that they can do about it. If it's exogenous, then again, you want to remove whatever's causing the problem. And you can also use topical treatment to help with some of the pigmentation. Your prognosis, unfortunately, if it's genetic, these are chronic diseases, right? Genetics don't go away, and it also means that they're progressive. For exogenous, these are cosmetic concerns only, so again, remove what's causing the problem, and you can also use topical treatment to help lighten up areas. So that's your ochronosis. Case 8.
Okay, little tiny nodule looking thing.
Yeah.
Not very terribly melanocytic, but it's raised. Kind of looks like a pimple.
Almost. Yeah.
Not without the erythema.
With, yeah. Okay.
Okay. there's definitely something at low power going on in the dermis here.
Yes.
And so there are melanocytes,
Mm-hmm.
lots of them, and they look a little weird. Some of these are a little bigger, but they're a little more. How should I describe this? Spindly, maybe?
They are more spindly.
Spindly.
Yeah, there are some epithelioid cells,
Mm-hmm.
which kind of stand out because they're huge, but most of this is very spindled.
Yeah. There may be some in the epidermis, maybe? I don't know.
I think those are just normal.
Normal base, yeah,
Yeah,
basal cells. Okay.
but
But they're
that's a
kinda
good thought.
Yeah, kind of spindly.
Mm-hmm.
What else is there?
Well, you can see a little bit of it. So there are all these spaces that are occurring
Okay.
that are not vessels, right?
Nope. Just some sort of artifact.
Some sort of artifact, yes.
Okay. Ooh, no, that's just blood.
Well, and there's one other thing that you can see. Well, I mean, like we're kind of seeing somewhat vascular stroma, not overly. And I don't think we see any of the other feature in this case, unfortunately.
Let's see, is there another piece?
No, it's
Nope.
just the
The one
Yeah.
time, huh?
the one time that there aren't like 3 sections and 3 levels.
Yeah. Alright.
Okay, so what do you think we have?
And the only thing I can think of is Spitz nevus because we haven't covered it yet. Although I don't know what that thing is.
Yeah.
So please
Okay.
help.
Okay, yeah, so this is a Spitz nevus. And these can occur in any age, really. And they're relatively uncommon. And again, face, trunk, extremities, we kind of repeat that over and over again. And yeah, these don't really look pigmented. They look more pink, red, and they're usually very small, and they can be mistaken for hemangiomas or pyogenic granulomas, lobular capillary hemangiomas, just because of their gross appearance. On microscopy, you can see all sorts of things. So remember with our acquired nevi, we had junctional compound intradermal forms. Well, the same thing occurs with the Spitz nevus, but your compound is the most common. These are very symmetric lesions, and you don't see lateral extension of the junctional nest. So what that means is whatever is occurring in the dermis, the epidermal component does not go past that. It doesn't shoulder past it. Can it occur? Yes, but in most cases it does not. The melanocytes in these are for the most part very spindled, but you can see epithelioid cells. So our case was actually mixed where you had spindle cells as well as those very large epithelial cells. And your spindle cells are often perpendicular to your epidermis, which we saw in some areas, but it was kind of unclear in other areas as well. You will see melanocyte clusters, or can see them within the epidermis, and you can also see that patchoid spread. So again, going through other things, the clefting is what we were looking for in the case where we were talking about the spaces that don't normally exist within the dermis. So that's an artifact that is often seen in a Spitz nevus. I don't believe there were camino bodies, which
I think
are
we saw one, like we kind of paused over one, but it was hard to tell if
yeah.
it was.
Well, they're usually at the DJ or
Okay, yeah,
dermal
then-
epidermal junction.
No, that was too big.
Um, So yeah, there was some stuff that looked eosinophilic, but it was within the dermis, so I don't think that necessarily fits. Again, someone can correct me if that is actually true. So I tried finding lots of pictures of camino bodies, just in case. And again, we're going to see that melanocyte maturation. So these are just features that you kind of hopefully are getting the hang of and seeing in all these different lesions. Some things that you can see often in spitz nevi are a very vascular or edematous stroma. I think our stroma looked fairly vascular. You can see PE or PH, pseudoepitheliomatous hyperplasia, which if you've gone over our lecture and cases from last week, you'd be familiar with that. And you can also see giant nevus cells. Our case did not have those, and it also did not have pseudoepitheliomatous hyperplasia, but those are things that you can look out for. So your differential, of course, there's something that involves melanoma that looks kind of like a spitz nevus. There's also several different, like spindle cell nevus of Reed, where it's again very similar looking, and as well as your conventional melanocytic nevi. So again, like you'd want to think about, is this simply just a compound nevus? Is this like whether it's congenital or acquired? And what they do for these is complete excision. The prognosis overall is relatively good. There's a very rare risk of malignancy, and when they excise them, there's a low risk of recurrence. So that's always nice. You don't want to have to go back and re-excise. Yes?
Question. So if we're going back to the spitzoid melanoma, is spitzoid just referring to a spitz nevus, or is that actually a pattern? Like, do you call something a spitzoid?
Well, that's a good question.
I feel like because I feel like it probably is a spitz nevus maybe appearance.
Like maybe it's something that like was a spitz nevus but then transformed into melanoma.
Because I don't think I ever recall spitzoid used with like just spitz other than spitz nevus.
Right.
So, okay.
But of course there's variance to everything, and this is where you definitely point out that I am not a dermatopathologist. And that's okay, because I am not. But I would imagine that it very closely resembles a spitz nevus, but there's atypia there that is not allowable. Like while we were going over the details of spitz nevus, what we didn't see is allowable atypia. So that's probably the difference, but I'm not sure. Now you know the drill. If you ask a question that we don't know the answer to,
I'll go throw. Just kidding.
It's a good learning point to read up on and get back to everyone. And yes, I do post things when they get back to me, but that so rarely happens. It's usually left on me to look it up. Okay, but that's our spitz nevus. So we're moving on to pre-malignant and malignant tumors. So this is case 9.
Very superficial, thin strip of skin with something. Alright. Oh, that's just debris. I think that's just debris. That seems like inflammatory debris maybe, or just, I don't know.
It's solar elastosis.
Is that solar? Oh my god, that's some crazy solar elastosis.
Yeah, it's just the way it's stained.
Okay. It just looked like it melted, so kudos. Alright, so looking at this thing, looking at the skin, the epidermis. Like this area I'm a little concerned about. It doesn't really resolve very well. I mean, there's definitely, I think, melanocytes here with the little clearing area. There's just, the cell borders are not very well resolved in this area. They look like they kind of run together, but I think there's too much something's going on here.
Okay, good. valuable point that even if you don't know what something is, knowing that it's not what you should be seeing is usually, like, that's the first step into investigating.
How does this gross lesion look?
So grossly, it's gonna be an irregularly shaped macule.
Ooh, alarm bell.
Yeah.
But it looks like it's mostly confined to the epidermis, whatever that's going on here.
Okay.
So I would say it's an in situ process, probably.
Okay.
Yeah. And since we're going to the malignant and pre-malignant cases, I'm going to hedge my bets on melanoma-in-situ of some kind.
Okay. That's what this is. This is melanoma-in-situ.
Although it's kind of, I mean, there's some bits, like, it's hard to tell, like, I mean, these cells don't look normal, but they're kind of, they kind of run together.
So remember, we have a very low threshold in Dermatopath for calling something too much atypia. There's a very low threshold, and the atypical cells that you're seeing, they're all melanocytes, and they're all at all levels. So whether they're like these look more normal, even though they're enlarged, but then you start seeing them up here, here, like they're just the features are atypical because again we have enlargement of them. Is that a mitotic figure? It's kind of hard to make out. But atypia involving melanocytes, all levels, but looks like it's confined to the epidermis. So this is melanoma-in-situ.
Oh, okay.
Oh, okay.
Is that lipoma? Just kidding. From far away.
I know what this is. So this is an IHC stain.
Oh, okay.
So what IHC stain would you like?
Melan-A, HMB 45?
So this, I believe, is HMB 45.
Yeah. Okay, well, look at that.
Yeah.
Oh, look at that one. Ooh, that's a beauty.
Yeah, so you see all this spread. And this normally should all be within the basal layer.
Mm-hmm.
But it's not. It's kind of everywhere.
Yes, it's beautiful. It's a pretty stain. Like you don't see much IHC stains that are red these days. They're mostly just
well, it has to do with the chromogen that they use.
Yeah.
So you have red chromogens and brown chromogens, and that's also how they can create combination IHC stains. Yeah.
At our facility, we were just used to looking at.
Yeah. So whether this is MART1 Melan-A, which MART1 Melan-A are the same stain, HMB 45. This isn't SOX 10. That much I do know for sure. So this is either a MART1 or an HMB 45. But this kind of clinches the deal for you. So melanoma-in-situ is uncommon, thankfully, tends to occur in elderly adults, and it's in sun-exposed areas. These are irregular, dark, asymmetric macules, so all things that we don't like. They tend to be relatively small and have irregular borders, so don't like any of that. On microscopy, they're going to have these atypical junctional melanocytes that are either going to be single cells, they have lentiginous spread, which means that they spread lengthwise as well as patch-choice scatter. So again, they're going outwards and they are going up into the epidermis, okay? So these will have shouldering, so even if you have epidermal nests or dermal nests, the single cells and the lateral spread will go beyond those nests, so that's what's called shouldering. Here we go, our spitzoid features. So spitzoid features would be very enlarged, atypical, bizarre, pleomorphic cells, which I don't think we really had that. We definitely had some enlarged cells, some atypical cells, but I don't know that that was enough to put it into the spitzoid features. And you can have this rather haphazard or irregular distribution of inflammation. Again, I don't think our case really had too much inflammation, but it was an extremely superficial biopsy. So you need to keep that in mind. Okay, so our stains. So this is what we were talking about. MART1, Melan-A, same stain. You can use tyrosinase, HMB 45, SOX 10, MIT-F. So different institutions will have their stains that they like using for melanoma-in-situ. The red chromogen is really nice for these heavily pigmented lesions because obviously if you used a brown chromogen, well, melanin pigment is brown anyway, so that can make it difficult to read. Some things that you can do, which we didn't really talk about, but with heavily pigmented lesions like the blue nevus, and what you can do is you can actually like bleach your slides and then run your IHC on it. But the red chromogen is just so nice at picking up these melanocytic dermal lesions. So those are things that you kind of want to keep in mind. So okay, what are we going to have in our differential for melanoma-in-situ NOS? Well, multiple different types of melanoma-in-situ, because of course there's different types of melanoma-in-situ. You'd also want to think about, is this an atypical or dysplastic junctional nevus, or is it an irritated or traumatized nevi that is just, it's either congenital or acquired, but it's just been picked at or irritated in some way, and that can induce this atypia as well. And again, we see that reed nevus also makes an appearance again. So treatment for melanoma-in-situ is complete excision with 5 millimeter or ½ centimeter clear margins, and prognosis for this is excellent. Okay?
I just want to add, I just found something. So spitzoid, the word spitz is actually in place for unusual.
Oh.
Because Spitz is the person's name, like Sophie Spitz, who actually first described this weird melanoma in people.
Oh,
so
yeah.
a Spitz nevus is like an unusual nevus, like
unusual nevus.
yeah.
Okay.
So spitzoid melanoma is unusual looking.
Okay, so something that has an unusual appearance.
Yeah.
Well, there
that
you
makes
go.
a lot more sense. Yeah.
Okay. Well, that makes more sense then, because I'm just kind of like, our Spitz nevus doesn't look that bad. Like,
But
okay.
I guess compared to normal nevus, it looks unusual.
It does, because
Yeah.
it's more spindled, and you
Yeah.
have the epithelioid. Okay. All right, so now we know. The more you know. Okay. So we're moving on to case 10.
Ooh, that doesn't look nice.
It doesn't look
It's
nice.
irregularly colored. Doesn't really come out too much, but it's a little uneven.
Mm-hmm.
But yeah, the irregular borders and the irregular coloring is definitely cause for concern.
All right. So here
Another
it
very
is.
superficial specimen.
Yes. Well, people generally don't like chunks of skin being taken out without good reason.
With good reason that they don't like it.
With good reason. Well. Yeah.
Okay. Well, again, just looking at this, it definitely looks a little weird. There's these sort of cells that look like melanocytes that are just kind of atypical. So if I don't see anything else as I'm going through this, I'm going to definitely call this at least in situ. But it looks like it's, here maybe. It's coming, maybe here. Oh, okay, look at that. It's kind of invading into deeper. It's kind of here. Yeah, look at that. Ooh, okay. I think it's going into the dermis here.
Is it still the lesion though?
Is it still a lesion?
Is it still the lesion?
Oh, the lesion. I don't know. Maybe. Let's see. Where did the mouse go? I think it froze.
I think it froze.
No. Yeah.
Now try.
Oh no, I think the mouse died.
Oh, that's great.
Just a second. There we go. It's resuscitated. We don't know for how long, but let's see.
Oh.
Okay, I don't know. I think it's still part of the lesion. Let's see. Going back. I think it is. It's coming
Okay.
through and invading, maybe.
I think you're seeing the melanophages. These are melanophages.
Oh, okay.
So remember, like they're big and round, but half the battle is spotting all these things. Yeah.
Kind of just there, but I don't know. It looks like another in situ case. I'm not really seeing anything definitively invasive.
Mm-hmm.
I'm looking at the edges. Yeah, I mean, there's definitely, you know, stuff going on here, but I think it's still in situ.
Yeah, and I think on the first piece you looked at with the nests,
Yeah.
that was the best area.
Yeah. So,
Okay.
okay.
Because those are all nested. So you can see how, I mean, it's kind of difficult, this power, but you can see how they kind of generally create these nodular areas. I think it's easier to see on the computer than it is on here. But they're nice and round, okay?
Mm-hmm.
And then we have melanosomes in the background that I think make this a more difficult lesion than what it actually is. Again, here you can see there's nice round areas.
Okay.
You can see the basement membrane.
So that's in situ nodular pattern?
Oh, so this is in situ, but this is superficial spreading type.
Oh, okay.
Yeah. So these nodules, like these very superficial nodules or nests, are kind of what help you figure that out. Well, it's the most common variant of melanoma in situ, so that's great. Happens in adults and more common in fair-skinned individuals. Sites can occur more often on the back in women, back in men, legs in women. So think about areas of sun exposure in both sexes. And as we can see, it was a variegated, broad-based macule with very irregular borders and lots of different appearances to it. Gray-white is kind of the one to pay attention to, because gray-white appearance is areas of regression, or areas where this is self-healing, for lack of a better word. And they average about 1 inch in size. So again, these are asymmetric lesions, very poorly circumscribed, as we saw, and you have this lateral expansion. So this more like lentiginous type spread, even though we don't really want to use that term, but it's a lateral expansion of these nests of atypical melanocytes involving the epidermis. And it's a relatively irregular distribution. So in the case that we had, they were somewhat confluent, which you can see, but you don't have to see that. And we did have those atypical melanocytes that were single, and they were kind of going everywhere within the epidermis, which again brings us to our next point, which is the abundant pagetoid spread within the spinous layer. So again, so that very superficial epidermal spread of these atypical melanocytes, and you can see the spread at the periphery of the lesion, which is what we appreciated. The pagetoid spread was on the outside, and our nests were more in the middle. You can see artifactual clefts. I think we had some in our case, but I honestly don't remember now. And you shouldn't see dermal invasion, so that's really important for knowing the melanophages versus the melanocytes. And you can have this really dense inflammation around the lesion, so that can make it very difficult to determine if you're actually dealing with invasion or not. Your stains, all the stains are going to be similar for melanoma, regardless of what type it is. Your differential, again, is going to be very similar. You want to add in that mammary and extramammary Paget's disease because of the pagetoid spread, and the appearance of Paget cells to these atypical melanocytes can be somewhat similar. Again, your treatment's going to be the same for all melanoma in situ, and prognosis for superficial spreading is excellent, which is great since it's the most common type of melanoma in situ. This is case 11.
Okay. More skin. Has a thicker, sort of more dense dermis. melanocytes.
Yeah.
They're very ugly looking.
They are.
Um,
So what's different about this case?
what's different, huh?
So what did we kind of see in our previous cases? Like, where were the melanocytes?
Epidermal.
Okay, well this is epidermal too. Maybe I should say where in the epidermis.
This one is more basilar.
Mm-hmm.
I mean, the other one has such a thin epidermis that it's hard to tell, but it seems like it went pretty much all the way up.
Yes.
Seems a little hard to tell without, yeah.
Yeah.
Okay.
But yes, the feature with this is basal melanocytes.
Mm-hmm. Basal, okay.
Okay?
Is it in situ still? Because I'm not seeing anything beyond into the dermis.
This is still in situ.
Okay.
So this is honestly probably the best area on the
Yeah.
slide. I don't have to torture you too much. This is melanoma in situ, and it's just a different subtype.
Okay.
So this is lentigo maligna type. Okay, so that's why I said lentiginous. Maybe we shouldn't.
What does the word lentiginous mean again?
So it has to do with just like lateral or
Okay.
horizontal spreading. So again, this is a very common subtype of melanoma in situ. That's why it's important to know. Again, elderly, slight female predominance. So whereas our other types that we saw today didn't really have a sex predilection, this one has a slight female predominance. And this has some other names that I can say Hutchinson melanotic freckle, but precancerous melanosis of Dubray. Yeah, I probably said that way wrong.
I don't even know which language source that name's from. Google. Give me 1 second.
Google. Okay, well we're going to keep going because we still have a lot to cover. So again, face, scalp, sun-exposed areas. These are very broad, flat lesions. Okay, they're non-palpable and they're slow growing. Just like all melanoma, they're going to be variegated with irregular borders, and these tend to be a little larger, so greater than 1 centimeter. And again, lentiginous proliferation of atypical melanocytes along the DEJ. So these replace the basal keratinocytes. That's why they occur along the basal surface. And you can have single cells like we saw in our case, or you can have irregular nests, or both. They tend to may have patachoid upward scatter, but if they do, it's going to be very focal. It's not going to be like what we saw in our superficial spreading where we had lateral and vertical spread within the epidermis. Your peripheral borders are really going to be hard to find because, again, these are single cells that are extending out laterally, and they can also involve adnexal structures, so that's something to keep in mind. You can have atrophy of your epidermal layer, and your reedy ridges can even be effaced, which means like they're going to be essentially absent. As far as inflammation, so we always see a little bit of inflammation within the dermis, and there is an inflammatory component with melanoma in situ, lentigo maligna, and it's going to be mostly lymphocytic, and it's going to be within your papillary dermis for the most part, so very superficial, and that can make it very difficult to identify where that basal layer is, where that DEJ is. You may or may not see melanophages in your case, and they may or may not be numerous. And of course, because this is related to sun exposure, UV damage, there's going to be solar elastosis. Again, our stains, exactly the same. The molecular for this, they tend to have increased rates of CCND1, which is a cyclin D1, increased copy number of cyclin D1, and they tend to have lower rates of BRAF. So BRAF is relatively common with melanoma. differential. So you have invasive lentigo maligna, like every in situ component, every subtype of that has a corresponding invasive type. You can think about, is this just solar melanocytic hyperplasia? Again, those dysplastic nevi come back, and so does that reed nevus. They just aren't leaving you alone today. But it makes it nice because the differential repeats again and again and again. So you really get a sense of what all these lesions look like. Treatment again, 5 millimeter clear margins, and again, your prognosis is excellent. So we have some examples of MART1 or Melan-A, as well as S100, just kind of show you where you're looking for your cells. And again, you can hopefully appreciate how those are all along the basal layer of the epidermis, and we're not seeing huge collections, well, really any collections within the dermis. So this is case 12.
Like a bump.
It's a bump. Okay.
Slightly discolored.
Yes. Yeah, that's
Kind of looks like a goiter. Actually, no, it's just between. Oh, it's on the side of this guy's eye. Okay.
yeah.
All right.
Okay.
Ooh. Okay.
Ta-da! Lesion.
It's very blue in the dermis.
Yes. So if our first years were here today, we would say yes, it's very blue.
Looks like these are all melanocytes
Excellent.
because it's, has that clearing weird, and it has almost like a spindly look. Kind of looks like a spitz nevus.
Yeah. I like all those things. Those all sound very good.
It's weird, but I don't know. We don't see much. It's on the ink, so
Right.
they're gonna
so
need to go back and revise that stuff. Oh wait, no. Oh, this is just weird. Okay, I think it's just like it's done. So it just kind of folds in the epidermis. Kind of looks like it's like doing that cuffing thing. Forgot the name.
Oh, the collarette.
Color, yeah.
Yeah,
That's
sort of. I think it's hard to kind of tell because it's oriented weird.
Yeah.
It looks like maybe it's ulcerated in some areas.
But I don't know if this. Okay, so it was on the ink on the other piece and still on the ink here.
Mhm.
But you do start seeing more of the normal dermis here. So it looks like some sort of elastosis,
Yeah.
aka just bluish junk. It does look like it's kind of maturing, I think, because the cells look a little bigger, but I could be just imagining things. I don't know. Maybe not. Never mind. Yeah,
Okay.
that's all I got.
So what is this?
I would say another spitz nevus, but we're past that.
We are past that, yes. Is this in situ?
No, because it's clearly not in the epidermis anymore. It's gone beyond that.
Okay. Is it atypical?
Well, I did say it's spitzoid.
Okay,
So
you
it's
can't call everything spitzoid now that you have a new favorite word.
It is unusual, but then again, melanocytes look kind of unusual. But I mean, it's not terribly unusual, but then again, you always say that derm-path people are very sensitive about atypia.
Let me go back a little bit. It's stuck. Can I see it? Yeah, I can. Okay. What about like this? I don't.
Yeah, that's weird.
That's weird. Okay, good. We agree. That's weird. It's a little more than spitzoid, right?
Is it spitzoid melanoma?
This is not spitzoid.
Just kidding.
So, okay. Remember I said, so every in situ has a corresponding invasive type, right? So what's the overall architecture of this, the overall pattern?
Diffuse. Nodular.
There you go.
That's a huge nodule, though.
Yeah, so this is melanoma nodular type. You can appreciate where it gets its name, and also from the clinical, because he looked like he had like a bump on his head, right? So yeah, second most common invasive melanoma is nodular melanoma. Again, we see a little younger population, so instead of our 70-year-olds, we're looking at our middle-aged adults. These can grow rapidly, and when they do, that confers a poor prognosis, which it makes sense, right? We have a malignant lesion, it's growing really fast, poor prognosis. Again, legs on women, back on men, so think about where you have sun-exposed areas. These tend to be dome-shaped masses that are raised and firm, and they tend to be symmetrical, which is a little different from what we've seen in other lesions, that like the other melanomas in situ, as well as other malignant melanomas. However, the coloration on them is still variegated, and again, wide range of appearances as far as pigmented, or they can even be achromatic. And they can be ulcerated or hemorrhagic, and this occurs relatively commonly. So it's hard really to make out what's happening in the scalp of that second lesion, because it almost kind of looks like there's some like squamous components, but it doesn't quite look like an eschar, so I'm not entirely sure what's going on there.
It doesn't look right.
It doesn't look right. Okay, so that's something like, you'd want a biopsy. Okay, so these tend to grow within the dermis rather than the epidermis, and the junctional component is very tiny or absent. So again, it's going to be almost entirely junctional, but if you have areas on the periphery that are involving the epidermis, that's totally fine. There tends to be there may or may not be a thin rim of collagen that's separating the nodule from the epidermis. It was really difficult to tell in our case. There wasn't a lot of epidermis, and then what constitutes the rim or not. But again, you don't have to see that. You may or may not see confluent nests of abnormal melanocytes, and these can either be epithelioid, they are epithelioid type cells. They have vesicular pleomorphic nuclei, as we saw. The nuclei themselves are very hyperchromatic. And what melanoma is known for is this cherry red, so like this dark, deep red macronucleoli. So the nucleoli is large and this deep red, but guess what? That is not specific to melanoma. So you want to make sure that what you're looking at are melanocytes, and then if you have the cherry red nuclei on top of that, literally the proverbial cherry on top, then what you're looking at is most likely a malignant melanoma. You can have mitotic activity, and it's usually within the deep dermal component, and you can have pigmentation as well. So remember, you can have achromatic lesions, so they may not have pigment, and you can usually find your melanin granules with stains. So what that means is if you did a MART1 or Melan-A, it would pick up those granules if you were having a hard time finding them. And you can also have either very focal, like cell-to-cell necrosis, or sheets or wide dispersed areas of necrosis. Your stains, same as we've seen with our in situ components. For molecular, BRAF and NRAS are your most common mutations. Again, your differential, well, there's our Spitz nevus, so that's very good. Superficial spreading invasive melanoma, as well as metastatic melanoma. So you want to think about that, right? Because you can have melanoma in multiple different areas. Maybe it was a different skin site even. So those are all things to consider. Treatment, complete excision with clear margins. So the Breslow depth of invasion determines like how wide the margins have to be, and that tells the surgeons, like, even if, let's say, they have technically clear margins, in our case it wasn't, there was still tumor at ink, but if they have clear margins, but it's not 5 centimeters out, they're going to go back and do a wider ellipse, okay? Malignant melanoma nodular type generally has a poor prognosis, and again, that has to do with, is it growing fast? Is it having increased depth of invasion? Ulceration is a bad sign. increased mitotic activity. There's a lot of different factors with melanoma that go into prognosis, but that is your second most common type of malignant melanoma, the nodular type. This is case 13. This is our last case for the day.
Right. The skin, I think the interesting part is here. Looks like, ooh, okay. Lots of, well, this is definitely melanoma. This is way too weird looking to be non. Yeah. So it's invasive melanoma because it's going to the dermis, and but it's not going in too deep. Is this like a superficial spread?
Yes, that is exactly what this is.
All right then, let's leave it at that.
And if you go more towards this side of the slide, you can see how it kind of keeps going for a good while.
Yeah.
So that also helps you out a little bit if you're struggling looking at this. But yes, this is malignant melanoma, superficial spreading type. So this is the most common invasive melanoma, and it is the 6th most common cancer within the United States. It involves adults, and the incidence increases with age. We go back to our slight male predominance, and again, fair-skinned individuals, often people who are fair skin, red hair, are more prone to developing these kind of lesions. Again, legs on women, back on men. These are relatively large macules. They average at least 1 inch in diameter. You can see from the pictures how variegated they can be with very irregular borders. Again, they can have a large range of appearances, and those gray-white areas, you can see a little bit of it maybe in the top lesion. Hard to tell on the bottom because it kind of looks wet, but those can be areas, those are areas of regression when you have those gray-white areas. And if you have a nodule, so it's not flat, you have a nodular area, then that is very indicative of a vertical growth phase, which means it is going down. So your Breslow depth of invasion is increasing. This is a bad sign if you're seeing that with this type of melanoma. So again, we have lateral expansion of those large nests of atypical melanocytes. There is radial growth phase, which we didn't see with the nodular type of malignant melanoma. You will see pagetoid spread within the spinous layer of the epidermis, because remember again, this is superficial spreading, so it involves not only the dermis but the epidermis as well. You will see these large clefts, those artifact clefts again, and our case actually had some really nice examples of that. You will have your atypical melanocytes involving your reedy ridges as well as your suprapapillary plates, and in these areas you'll have the melanocytes will be more enlarged epithelioid, but you'll have that nuclear pleomorphism. The nuclear membrane is often thick or irregular, and again, those prominent cherry red nucleoli. Can't really stress that enough. Within the dermis is honestly where you're going to see most of your mitotic activity. So what's also important to note with this is that where we were talking about the maturation with the base of the lesions, you don't see that within these lesions. So there's a loss of maturity, failure to mature, So what that means is that the size of the cells at the superficial aspect of the lesion will be the same as the size of the cells at the base of the lesion, okay? So your NC ratio will be the same. These often have a very dense lymphocytic infiltrate, and you can also have that irregular melanin pigment in the dermis. We saw that in our case. Most of the melanin pigment was more in the superficial or papillary dermis, but it can just kind of be anywhere within the lesion. If it is BRAF mutated, you will see increased upward migration, okay? you'll have melanocytes, intraepidermal melanocytes that are nested. So instead of those single cells, you'll have nests. And the cells will be more epithelioid, more pigmented. If there is an NRAS mutation, you will not see those features. So that's actually a nice way to, like a quick way to kind of figure out what your molecular profile is going to look like in these. Again, our stains are all the same, the molecular is the same, but you do have the added benefit of those histologic features that you can kind of figure out, is this BRAF or NRAS. And again, our differential is pretty much what we've been seeing all night, where it's severely dysplastic compound nevi. Is it an atypical reed nevus, because we can't just stick with reed nevus at this point, there's too much atypia. Is this, again, a metastatic melanoma that's involving the skin? So that's what epidermotropic means, is that, metastatic melanoma to the skin, as well as Paget's disease. Again, your Breslow depth of invasion is going to determine how wide the excision has to be, and your prognosis, again, depends on your Breslow depth. Is there ulceration? What is your mitotic activity? So all those things are important for figuring out what's going on with these cases. What is the overall prognosis going to be for the patient? So malignant melanoma, superficial spreading, is your most common type of melanoma. And it's nice having the stains be very similar across all of those, whether it's in situ or invasive. And again, the difference between the red chromogens versus the brown chromogens, and just keep all those things in mind. So that's the end of the cases for this week. We do have 17 cases for you in the challenge cases, and we will put that video together within the next few days, hopefully. And if you like this video, please hit like. If you aren't subscribed to us, please hit subscribe so you can be notified of any new content. If you have comments, questions, things that were confusing, please feel free to add them below. I don't think we have anything in the chat, but if anyone is on that has questions, we can do our best to answer them, although clearly, as today has shown, thank you. I'm by no means a dermpathologist, but these are lesions that we see often enough, and they can be very confusing, very challenging if you don't have a strong dermpath background. And again, because their skin in multiple areas, in multiple subspecialties, these are things that you'd want to know. So whether you're looking at, breast, bone soft tissue, GI, because you can have melanoma involving the GI tract, really any of the surfaces, you can see these lesions. Something that I didn't point out is that melanoma that involves the brain or neural tissue, those are almost always amelanocytic, okay? So you can't rely on the melanin pigment, but the nuclear features and all those other things should be very similar. And with that, we're going to sign off for this week, and we will see you next week at another slide review.